Good afternoon, everybody. This is Zurich, 3 o'clock in the afternoon on Thursday, January 13th. And it's freezing cold in Switzerland, it's freezing cold in Europe, and millions of Europeans are suffering from aching joints and stiffness of their joints. This can be early OA. This is why we're here. Welcome to the ICRS webinar on early osteoarthritis. We have registrations from 65 countries all over the world. So greetings of the day, wherever you are in your place, and welcome to that webinar. And it shows that early osteoarthritis seems to be a pressing problem, not only in Switzerland, where it's cold at the moment, but also all over the world. For that reason, we put together this webinar to find out and share with you and share our ideas about early osteoarthritis, to early diagnose it, to treat it, to maybe prevent it, this early OA, and make life better for all of us, maybe. For today's session, I'm honored to have on stage with me two world-renowned specialists in the field, Professor Nehrer from Austria, and Professor Lattermann from Boston in the US. And my name is Chris Erggelet. I'm an orthopedic surgeon in Switzerland, and I did a lot of research and teaching at the University of Freiburg in Germany on cartilage engineering, basically. Regarding the format, we will present 3 talks where we each share our ideas, our perspective, our new developments on early osteoarthritis. We cannot cover the topic in all wideness and depth, because that would put us to a one week symposium, but we will try to give you some pearls and ideas from our side, and we try to trigger research and treatment regimes on your end of the world, wherever you are. At the end, we will do a question and answer session where you can chat with us and send us your questions, and we try to answer them, or we have to admit that we cannot answer them, which might be possible as well. So let's dig right into it. We will start with a presentation from Professor Stefan Nehrer. Professor Stefan Nehrer is a long-time specialist in the field. He's from Vienna, Austria, and at the moment he is the Dean of the Medical Faculty and the University of Krems in Austria, and he did a lot of research in the field of cartilage repair, cartilage biology. And so now he is meandering on a new field, X-ray analysis as predictor for OA. How can we find out? With only then, if we know that, we can treat it and can prevent it. Professor Stefan Nehrer, please, the stage is yours.
Christoph, thank you very much. Hello to everybody worldwide. I'm very happy to be here, and also freezing Vienna, but it's quite good and cozy for this webinar this afternoon or in the morning or whatever you are all over the world. And in these difficult times, I'm very happy to present our experience here on the early osteoarthritis or detection of osteoarthritis, because diagnosis comes first, as we all know, when we have to treat different conditions. And so we actually started 5-6 years ago to deal with this problem of analyzing X-rays, or really dig into the deeper sides of data in imaging. This is my disclosure here, where we're collaborating with a company which is a spin-off of Technical University and other universities, Imaging Biopsy Lab, former BrainCom, which are actually the computer guys. We are the orthopedic surgeons in this place, or myself. So to know about algorithm and computer is quite a different thing here, but thanks to the guys there. When we look at the drivers to hell, as our webinar is named, there are multiple of those. It's the aging. We know age is a really substantial driver of osteoarthritis. Obesity, overweight and loading can do that, on also sedentary, because the locomotor system is also, of course, depending on movement and also adapting to load. So if we don't do that, we have a problem, and especially in this time when we are at home looking at Zooms and just sitting in front of our computers. And this all leads, of course, to a high prevalence of osteoarthritis, also in Austria, as you see here, as in Europe, as worldwide. And WHO has actually named OA as one of the major burden diseases worldwide. It's assessed by clinical scores, but today we want to talk about radiological assessment, which are Kelvin-Lorentz and OASIS scores, mostly published scores, as you see here. So it's quite a load on the radiologists when you look at that. What globally happens, how many people are affected, how many X-rays or imaging analyses are done on the musculoskeletal system, and actually increasing demand of the radiologist to follow up disease of the locomotor system, especially in osteoarthritis during the last decades. But still, the process is very manual, actually. When we look at that, like almost 100 years ago, we look at an X-ray and kind of describe the condition, joint-space narrowing, sclerosis, and whatever. And actually, the description of these radiologists are very different. They are very subjective. And when you look at different opinions to an X-ray, you find most often different options. If osteoarthritis is more moderate or is less severe or whatever. And this, of course, although we have a real data set in our hand, when we look at the DICOM format, it's about 5 megabytes. We don't really objectively analyze this mass of data we have in hand. And also, we should be quicker and maybe more objective with that. So there's a high demand of that. Also, when we look scientifically at the problem, that we see if we have such a blurred outcome parameter, which is not so exact and still very subjective, this leads to also difficulties in kind of designing study designs for osteoarthritis, and maybe part of why some of the osteoarthritis studies are not so evident or reaching high levels of evidence and significance might relate it that the outcome measurements are quite subjective. And just a few studies really use objective measurements in really measuring osteoarthritis dimensions in a knee. And so when we look at the Kelvin-Lorentz score, as you see here, progression of osteoarthritis in different grades, we have 4 parameters here, and all of these parameters are graded in semi-quantitative analysis of grading systems. So it's actually a multiplication of a subjective interpretation of a parameter when you look at Kelvin-Lorentz score. So no wonder actually the interscore agreement rate is very low when you look at that. To have the same measurements or the same characteristics in a Kelvin-Lorentz score is very low. And also the prevalence of osteoarthritis, even this, if osteoarthritis is present or not, is actually not very high when you look at the low agreement rates here in this small study set. And actually, this was one of the backgrounds where we really started to get closer and also get in contact with the computer specialists and started to learn the computer how to assess osteoarthritis by learning the different parameters and grading them by assessment on the digital data set, which is an approach they call machine learning. So you actually learn your computer how to assess the joint space width and how to assess sclerosis or the osteophytes, and actually then adjust it to a score in the Kelvin-Lorentz score. The first thing we noticed here that also when you just look at the joint space width, there's a difficulty really to look if the person has OA or not. If you look at these two persons here, which are quite a difference in height, you see both have a joint space of 4 millimeters when you measure it. But still in the small lady, 4 millimeters is non-OA, whereas in the big guy, joint space of 4 millimeters already moderate severe, moderate osteoarthritis. So just the number of joint space width doesn't really tell if osteoarthritis is present. So actually digitally, we kind of increase the size of the person and standardize it to the height. And so when you do that in a data set, you see that the joint space width in a kind of standardized situation is 2.2 for the big guy and 6.2 for the small lady. So there's a clear distinction now between the person who has a way or who hasn't a way. And when you look at big data, because big data is also part of the topic here, you really need big data to assess that. And you see the red line that you have here, progression with the height of the person, whereas when you use the normalized value, you can really have a comparable set of data. And we published this 2 years ago with Diego Baixo of the group, and we could show that the standardized joint space really allows better distinction between the different grades of A and cancels out the variation of height difference, which is actually a quite nice approach in standardizing your data set. But still, this was not enough really to move forward, because we had especially problems when we look at sclerosis, deformation, and all the other parameters of osteoarthritis. So we actually exposed our data set, which is from the Osteoarthritis Initiative, of 22,000 individual knees, 3,500 patients, in a deep learning process, which actually in the feed forward and feedback loops really analyzing in an algorithm your data and kind of learn the patterns of osteoarthritis and kind of with feature extraction and classification kind of adjusted to the ground truth that you give the computer, and then the computer is learning what is away and what is not away himself out of the full data set. And with that, we could show that we could really increase the sensitivity of this in this compared to other assessment. Also, the average of measurements of the joint space width really had a very small error to which leads to more comparable values here. So this actually led to create of a computer program which you actually can have on your laptop, which helps you. It's called the Koala system, the knee osteoarthritis assessment tool, and which helps you to assess such a plane X-ray as you see it here. And then you get a kind of an overlay giving you the result of the computer analysis, and then you can, as a doctor, agree with that or kind of modulate it. And then this helps really to have a more standardized data set. And we looked at that in a data set as is shown here from 120 patients, where we had all the variabilities of different grades, different age, different ethnicity, to have all and body mass index, to really have X-rays from all the groups that are possible, to look if our machine really has learned to assess that. And when we see that, the blue is the unaided and the red is the koala aided in this interclass correlation, you see that we get increased values here with a higher agreement rate when we use such a program. And this, of course, leads to a more standardized analysis of your cohort when you're analyzing a study, your osteoarthritis. So you get a higher specificity with that, and which actually leads to a decrease of your false positive interpretation of an X-ray. And when you also look at these rock curves, you see that actually the use of such a system leads to a shift to the left, which means more accurate diagnosis, not over-diagnosing osteoarthritis in X-rays. So increased readers agreement rate and decreased reader specificity was the result of this study, which was published in the ICRS Cartilage Journal. It's also an educational tool, as you see here. We use junior radiologists and senior radiologists for readers assessing X-rays, and then they were aided and unaided, also with the system, without the system. And also here that we get a much higher standardized pool of results at the end, more harmonized data pool when we look at that, and not so high inter-agreement variation when you look at that. And most interesting was that the seniors here that you see here were actually way more off the ground truth of this cohort than the juniors. So obviously the seniors are not so following the rules of how to assess a Kerguelen-Lorentz score. So also for them, it's quite helpful not to use just experience, but to have a more objective aids to assess osteoarthritis. Also, when you follow your osteoarthritis patient, you see here 1 year follow-up. Here you see OA is already present. 1 year later, it has increased. And also here, there was no OA present. Less than 2 in Kelvin endurance score means no OA present. But you have slight decrease of the joint space. So you have initial signs of OA, and this is very important because there might be the same Kelvin endurance score, but there's a small progression. And when you look at 1 year steps of following your patient, it's very important that you also see those subtle changes of initial osteoarthritis, which is going on, and progression is actually the key here to analyze the progression. So it's very interesting if you have here 2 X-rays and then kind of have some clue who of those 2 patients would progress 5 years later. And we see in these patients 5 years later, one, the red one has progressed, the other one not. And when we look at the slope of the progression of joint space narrowing, there's a vector appearing here, a downward vector of the joint space narrowing. And you see here that obviously there was no sign at the beginning. And so we analyzed also by using algorithm of 4,100 patients, also big data sets, which we exposed to our Koala system, and then did an analysis of that, who would be a predictor of progression of disease in this case. And when we look at that, we get, especially here, you see sclerosis of tibia and femur, which is a quite high predictor. Joint space narrowing, of course, is a predictor, because if you have already joint space narrowing, this might progress more. But there are other signs like sclerosis, increasing our ROC curve here. But when you look at osteophytes, for instance, we didn't know that, or I wouldn't expect that osteophytes of the tibia are not, in this case of, in this study, were not a sign of progression of disease. It's a sign that OA is present, but not of progression. So I think that's a quite important information. So the subchondral bone, the sclerosis, was something which we're very interested. We know that there are a lot of hypotheses about where osteoarthritis starts, and also that we have subtle bone changes in the early OA phase, showing us that there's something going on the subchondral bone, which later on is followed by the changes in the articular cartilage, or vice versa. We don't know it actually finally, but we see that we have early changes in the subchondral bone. So we analyzed the subchondral bone by fractional analysis, also a mathematical model, showing basically entropy of the system, if it's regular or if it's not regular, and also changes of the gray pixels here, which were compromised to a bone structure value in this mathematically. So we have a more closer look to the subchondral bone, which you don't see by bare eye, that there's something happening, but the pixels, the data set can show you that. And this was our analyzing algorithm. We used 4 fields in the tibia and 2 in the femur. We had also here a data set of about almost 600 patients, and part of those patients did not develop osteoarthritis or didn't have osteoarthritis at the baseline, and that the follow-up, some of those developed osteoarthritis. And so we look back, what could the bone structure value help us to predict this? And actually, then we used a variability of different parameters adding up in the predictive value, like body mass index, joint space, or also the femur textures, the bone structure value. And we saw here that we get increasing good values in the ROC curves, which means there's a higher prediction rate in that if osteoarthritis is happening or not. So you can include such a system in your TICOM in your PAC system, and have it as an overlay, as an immediate, just on a click, you get this information. So it's also actually very cost-saving time. So overall, this advantage is that we have a 92% precision rate compared to the ground truth. Also, the accuracy is about 93%, and we get also increase of the agreement rate, which means much standardized analyzing when you look at study evaluation or whatever. So it can help to take over low-risk, time-consuming tasks. It can also, of course, measure angle, distances, volumes, as you have seen. Also can give you a hint of lesions and anomalies. and more important is consistent reproducible results for your studies and actually a streamlined workflow. So we're coming from a more reactive model of the disease. So we look at the disease and then we act with our symptom or modifying drugs. So with pain treatment or knee arthroplasty at the end. So we want to come to a more proactive model where we have early signs of osteoarthritis, actually increase our prevented and targeted treatments, and also have a clear monitoring of the progression, which is also very educational for your patient. So what we are talking about today, this way to hell, which means the total knee replacement here should be stopped, and the earlier we can stop it, we are more successful by prevention of osteoarthritis. And I think that this is the better way than just to treat the systems. So a more digital standardized than subjective manual is maybe the way we go in this digitized environment that we are facing. So with that, I'm happy to host you as a scientific chair in Berlin and hope you are there more personally, not on the Zoom. And with that, I thank you very much for your attention here to this talk. Thank you, and I give back to Chris.
Thank you. Thank you very much, Stefan. That was impressive. And the idea of have a tool, an easy tool on site to find out whether you are endangered by osteoarthritis, whether you have osteoarthritis, that you can react early, that's really amazing. Great work, Stefan. We will continue with Professor Christian Lattermann from Boston. He is a professor at Harvard University, and he did a lot of work on biomarkers, and he tried to establish a system where you can detect early OA by blood analysis, by effusion analysis. And so he tries to do the same thing as Stefan Nehrer wanted to do or wants to do with the X-rays. So we are keen to hear about the latest developments in biomarker developments for detection of early OA. Christian, welcome, and it's all yours.
Thank you very much, and thank you very much for the introduction. And I hope that you guys can see my slides at this point. I'm hailing from Boston. It's morning here. We have people from all over the world. So whichever time of the day it is, I hope we're not going to bore you too much over the next 15 minutes talking about inflammation in OA. I do have some disclosures. So inflammation says it all. Biomarker staging and prevention is my talk. That's actually the easiest talk in the world, you know, because to be honest, I can't fully answer those questions as of yet. But what I will do is I'll put you through the emotions of where I think we currently are and where we will be going over the next few years. The success story of cartilage repair is really kind of depicted here over time. We are really good in fixing potholes. What we are, however, approaching at this point is whichever technique we are using, we are pretty much kind of sort of about as good as we are going to get. I do not expect much improvement there unless we are kicking it up into the next level. And that means controlling the progression of osteoarthritis, which most of these patients do. We can have about a decade of good functions with our current techniques. Chronic inflammation continues to be a problem, and PTOA is progressive regardless of age. We know that joint injury is the initiation of osteoarthritis. It happens back here when the joint still looks normal after an ACL tear or so. These are molecular changes that start, and then they turn into physiologic changes when they affect structure. Then they start looking like this. This is when the patient becomes symptomatic, and then the actual phase where you can treat them early is very, very short, and we typically miss it. And then we start basically trying to pick up the pieces at the end, trying to do some cartilage repair and eventually a total knee replacement. So if we can get to this up here, we have a much better way of actually treating the disease rather than palliation. And we do know that it does lead to progressive inflammation. The molecular tissue damage is associated with that. We see that immediately after injury, all kind of structures in the joint, from the synovium to the cartilage, the synovial fluid, the subchondral bone, etc., is undergoing changes. And much of that is driven by an early inflammatory response. And then that goes along with a significant chondral breakdown. We've shown that in numerous studies and randomized trials over the last couple of years. The other problem is that this actually is progressive over time. So it does not resolve by itself through stabilization surgery alone. In an ACL model, for example, fixing the ACL alone does not solve this issue. About 1/3 of ACL patients have pain at 2 years, and that is associated with increased inflammatory levels at the time of surgery, actually. So in patients that have high levels of chemical indicators of chondral damage and inflammation at the time of surgery, that is very highly associated with worse outcomes at 2 years. Now, this is not just us saying that. This is also the group with Eva Roos and Stefan Lohmander, who very clearly point out that about 50% at 1 year and 66% at 2 years perceives their symptoms as acceptable. That means 1/3 of patients at 2 years is clinically symptomatic for OA after a simple ACL injury. We know that biochemical changes result in structural changes that can be imaged. There's multiple studies that evidence that. One of the earliest one was work that was done in Belgium by Peter Verdonk, but just recently, Brian Pitcher-Simone showed us again that the profiles of increased serum levels of inflammation and matrix degradation markers preoperatively are associated with MRI changes at 12 months post-op. And you can clearly see that in the lateral tibiofemoral cartilage where the proteoglycan density goes way down. So there's clearly structural changes that can both be imaged as well as detected chemically. We have further looked into that and to try to figure out if there is maybe a relation between the way that the inflammation happens in those that are getting worse. And what we have been able to find is a cluster of patients who are having an inverted ratio of inflammatory versus pro-inflammatory factors. So if you look at we call that the dysregulated inflammation cluster, those are patients that have a very high level of a relatively high expression of IL-1RA, as opposed to the ones that have low inflammation. However, if you look at the levels of IL-1 that they have, because these two interact, obviously, the ratio is completely the opposite. So in other words, this is a much more inflammatory environment than in the low inflammation cluster group. And the interesting thing is if you compare that to the outcomes, those are the ones that are doing fine, and those are the ones that are doing worse. So there is slow progressors and fast progressors, just like Stefan Nehrer pointed out earlier on radiography, and that has to do with the level of inflammation that is maintained throughout these joints, and it actually starts right at the time of injury. So this is a chronic inflammatory process. And the fast progressors show this dysregulated inflammatory response. We call that the inflammatype, and this is a subgroup of patients that basically doesn't do well. This is also the group of patients that we need to identify early, because if we can identify these, those are the ones that need treatment. Now, the problem is how do we treat them? The other thing that is important to understand is this is not just for ACL injuries. We have recently repeated these data in patients who underwent knee dislocations. And if you see in the red box here, there's clearly a difference in terms of age and BMI between patients that tear their ACLs and patients that have multiple ligament injuries. However, if you look at all the biomarkers, there's no difference whatsoever. So they undergo the same process. And the interesting thing is if you look at that more carefully and look at the actual pathways of genes that are being stimulated and inhibited between the initial ACL injury and then the 4 weeks after ACL reconstruction, you see that there is a change in the actual pathway. So the inflammatory pathway genes get dialed up way up, and the structural pathway genes that are supposed to maintain the joints are dialed way down. So this is actually not what we want to see. We can influence that and intervene with things like corticosteroids. I've talked about that for many years now. You can technically reduce the degradation of articular cartilage, here measured as CTX2, if you give cortisone at various time points and various dosages after the ACL injury. However, this is not really necessarily the most desirable of all approaches because it's kind of sort of shooting cannons at birds. The problem is that unfortunately, when we're doing our ACL surgery, we reinitiate this cascade that we had previously been able to drop down by using triamcinolone acetonide. This is a trial here, the HEALER trial, where we gave triamcinolone acetonide to everybody in order to verify what we saw in that first trial, and they stayed relatively low. But then a week after surgery, it starts going back up again for CTX2, and the same thing is for the inflammatory markers, IL-6 and IL-1 beta. And so what that unfortunately means is that even if we calm it down initially, when we do the surgery, the whole process starts up again. How do we know this underlying inflammation is bad? Well, we know that from some work from Albrecht out of Regensburg who showed that high IL-1 beta levels in biopsy tissues after cartilage transplant is associated with failure, right? So this is not good if you have a chronically maintained inflammatory response. And can we predict the failure? There's some really interesting work out of the Oswestry group who looked into certain biomarkers for that. And the more interesting one is probably ADAMTS4, which is a proteinase. That is something that we don't want to see typically in the synovial fluid. And if that is present, it is associated with a much higher level, higher associated 3 to 4 times the odds of being a non-responder, in other words, being a failure. The only problem is this is actually really difficult to detect, and it is something that is not routinely available at this point. So the answer here is definitely maybe, right? So this is not really totally satisfying. We also know that this chronic inflammation that happens, it has other functional consequences. It influences, for example, your quad function. And it also secondarily, even as long as 6 months after the initial ACL reconstruction, those patients that had very high IL-1 beta levels at the time of surgery have an increased knee adduction moment when they are ambulating compared to the others. So that is probably a pain-related pathway, but it does influence how you walk and potentially compounds mechanical aspects of beginning knee OA. So the key points that were recently concluded in Nature Review in Rheumatology in 2021 by Mahmoudian basically say early stage knee OA could present a window of opportunity. We need to understand the molecular cascade. The goal is to do better classifications, have a multidisciplinary approach to that in order to do early diagnosis. Well, I mean, to tell you the truth, the ICRS had a conference back in Tokyo in 2016. Well, you know, we already said it back then. This is nothing new, and this is in Nature, the review of 2021 now. So we really haven't moved much forward since then. So we need a measure of the inflammatory burden, and that needs to include imaging algorithms such as the one that Stefan has shown you. Biomarkers of inflammation play a role, but they are not the only solution here. We need visual markers of synovitis, either with ultrasound, needle scope, or regular scopes. Symptoms and functional parameters that play a role in that. So that's what we should be doing today. And to tell you the truth, we can do this today because all of these things are currently collectible information. So this is actually doable at this time. And this is one of those things that I'm working on right now over the next probably 2-3 years to try to come up with some sort of a measure of inflammatory burden. And I would challenge everybody else to kind of think along those lines. So what does the future in biomarkers show us? Well, there's going to be a lot coming out of interactome and network theory, which is kind of sort of along the lines of what I showed earlier with pathway analyses, where you can basically look at chemical interactions of molecules and enzymes and see how they potentially may respond, and you can basically calculate that. And the other thing that I think is going to move us forward is single cell RNA analysis, where you actually look at specific cell groups and how they respond to certain situations, particularly in the realm of osteoarthritis and chronic inflammation. This has been really a game changer. Now, let me talk to you for a couple of minutes about one of my recent kind of interests, and this has to do with process-resolving mediators. So in acute inflammation and health, we have the initial onset of inflammation, and then at one point that inflammation calms down and goes away. ideally. Now, if you have an overshooting inflammatory response, that is a really bad thing, and that can lead to basically disseminated intravascular coagulation and then finally death. Now, fortunately, doesn't happen very often. But what you can have is this resolution process here is not just something that just goes magically away. That's actually actively controlled. And sometimes that can fail. And then you end up with subclinical chronic inflammation. And that has to do with a switch of an inflammatory condition that is driven by prostaglandins and leukotrienes, and then switches over to a more cellular monocyte or macrophage-driven response that goes through a completely different system. This is called special or specialized pro-resolving mediators. And those are actually active agents that switch off inflammation and start the anabolic process after injury. So in other words, you get an acute inflammation, and then normally you would go from the prostaglandin phase into a lipoxin phase, which is the substrate basically for the resolution, and then it resolves inflammation. If that doesn't happen, it turns into chronic inflammation, which in every tissue, and that includes the joint, leads to fibrosis, structural damage, and scarring, and then in the knee joint to osteoarthritis. And these are the actors: lipoxin, resolvins, marrescins, annexin, and protectins. Those are basically the actors that play a role here in the resolution, and particularly for the resolution of inflammation in the joint environment. The ones that we are interested in are the resolvins and the marrescins. Why does it have my attention? Marrescin 1 is involved in the M1, M2 macrophage conversion. This is a really important factor that drives chronic inflammation. So the M1 macrophage creates a lot of IL-1. The M2 macrophage does not. And that is an important factor. RBD1 and marrescin are very highly abundant in platelets. Now, think about our efforts in orthobiology. So this could be a really interesting pathway to look into what PRP actually contains, because we do not have some indicators that it is pretty high in marrescin and RBD1 and could therefore actually be potentially a therapeutic approach. And it also interacts with the lymphocytic system with T regulatory cells and IL-17, which becomes more of an interest in chronic inflammation in OA recently. So what do we know? Does it actually happen in ACL patients? There is some work done in Italy by Marco Turati and his group. It's a relatively unclean group of patients. They are kind of any time between a few days to, I think, over 400 days of ACL injury. However, what he did do is he looked at younger patients versus older patients and found that in patients who have ACL reconstruction and are older, or ACL injuries and are older, they do, this is the ASS group, they are very, very low. And in the adolescent group, they are much, much higher. So there is potentially an age thing. And why is this relevant? So if you're looking at chemical mediators in general, chemical mediators and inflammation, they are very potent proteins. And if you look at where these resolvins are sitting, they work at the 10 to the 14th molecular concentration. If you just look at things like TNF-alpha or histamine or prostaglandins, they are multiple magnitudes of concentrations higher in order to get an effect at all. So this is very, very potent stuff. And we have actually looked in our explant culture model. You can influence the experimental inflammatory condition or osteoarthritis induced on explant models with the marrescin 1 very well. And so this system actually does play a role here. So to conclude, PTOA is a young person's disease. Inflammation after joint injury is chronic, unresolved condition. We need cumulative burden of OA measures. The current mitigation strategies address only the first phase of inflammation, not the resolution of inflammation. And understanding inflammation as resolution in chronic inflammation and PTOA is imperative to move forward. Thank you very much. And then I stop sharing right here.
Thank you very much, Christian. This is looks like bright future, but as you said, long way to go. This is definitely a work in progress here. And what do we do when we finally find out that we have early osteoarthritis? This is the question, and I can imagine that some of you are in that position, that you see your patients and they ask you, what can I do with my patients? And first of all, you have to make sure that you know, is that a cartilage defect in a healthy knee? Means that the knee is healthy and there is an accident happening or overload, and is the cartilage destroyed that way? Or is it an unhealthy, as we heard, inflamed arthritic knee with cartilage defects? This is the number one decision you have to make. Either fix the cartilage defect in a healthy knee, or you go to the inflammation, as we heard, because a chronic inflammation will destroy the knee joint. What you do with an unhealthy knee, a hurting knee, everybody gives it rest, spots, pause, put it on crutches, or distraction to unload joint or do osteotomies. We heard about weight loss. This is a constant and unloading of a joint, and it is done with healthy nutrition. As we all hear, this is the solution of all problems. If you eat vegetables and fruits all the time, and don't eat this, never ever. And if you eat this, then only in small portions. And we all know that that doesn't work. If you want a patient with joint pain to exercise, to build up muscle, you cannot feed him with like this. And some patients, they don't have the discipline, or they have metabolic disorders, and they need maybe something else. And I stumbled upon this here, that for diabetes 2 patients, an anti-diabetic drug can help to lose weight. The mechanisms are not fully understood, but there is semaglutide, for example, which is proven even for non-diabetic patients to help with weight loss and control the blood sugar, even if it's not apparently high. So that can help your patients indirectly to unload their knees and to help to treat early OA. Then you have all those anti-inflammatory ingredients, omega-3 and type 2 collagen. Soya and avocado is the only substance which is recommended by the Cochrane Foundation to be helpful against early OA. And then vitamin D and C, and then you have antioxidants like green tea, but you cannot drink liters of green tea. That comes in little capsules. Vegetable concentrations, and late studies show a good antioxidant job, which is done by resveratrol. Resveratrol is contained in red wine, for example, and you can add concentrated little capsules, but on the resveratrol field, there are two, if you have any more questions about that. Then the Cisadoa, symptomatic slow acting drugs in osteoarthritis, mostly glucosamine, chondroitin sulfate, and hyaluronan. This is well known. I added some literature at the end of my talk to be downloaded later on. But we all know that glucosamine and chondroitin sulfate, they are part of the cartilage matrix, and they should stimulate in vitro at least the proteoglycan synthesis, which is necessary for stable cartilage. HA acts as viscosupplementation and inflammation inhibition, regeneration of cartilage matrix, and which it is mostly used at injections, 3 or 4 sets into the affected joints in order to regenerate the physiological joint environment. But it might be interesting to know that you can do it orally as well. Some late studies show that it may improve the symptoms of early knee OA, at least in younger patients. And the oral intake as highly significant reduce chronic pain in early OA. So that might be interesting to look at for your patients. What do I do? I have a mixture. That might be the solution for now, that we combine in one product collagen, amino acids, glucosamine and chondroitin sulfate, HA, MSM, and the necessary vitamins. So that might be something which you can do nowadays. Does it help? We do not exactly know. Maybe we can help with the X-ray analysis, which we heard, the Koala system. We can control treatments like that and make the patient confident that it helps, and we can prove the value of treatments like that. Then the magic potion from Germany, Kobe Bryant made it popular. The magic potion, which he came over to Germany for and get his injections. And it should help against any tissue lesion, injuries of tendons, ligaments, muscle, bone, nerves. Lots of studies were done. And we had a hyperphase where we thought this can be used for everything. I'm talking about PRP, platelet-rich plasma. Platelets are the thrombocytes. And they're in your serum, and those thrombocytes, they contain or secrete proteins, growth factors, PDFG, TGF, and so on. And those growth factors on the other side are essential for tissue regeneration. They recruit undifferentiated cells to the site of the injury and trigger mitosis in those cells. So basically, it should be possible with this platelet-rich plasma, with a portion of the plasma containing above baseline platelet concentration, to control inflammation in the knee joint, or in other joints, or in other tissues, as an inflamed and thickened Achilles tendon is shown here. As I mentioned, there are a lot of studies out showing that it is improved, that it's a little bit improved. This study here by Brian Cole, as an example, more studies at the end of the presentation, they combined in a controlled prospective study hyaluronic acid versus platelet-rich plasma, and they came to the conclusion, basically no difference between hyaluronic acid and PRP at any time point. Significant improvements were seen in other patient-reported outcome measures, and a trend towards a decrease in two pro-inflammatory cytokines that could be controlled with new techniques developed by Professor Lattermann. We will see what the future will bring. At the moment, on the other side, no side effects, and we use it on a regular basis. Does anybody has heard about pulse signal therapy? This is marketed in Europe heavily, and it uses electrical currents in order to increase the blood flow and the healing capacities and capabilities of cartilage. And this is what it can do: non-invasive, surgery-free, drug-free, and so on. And 9 to 12 sessions, 16 minutes each. You can imagine that at least somebody benefits from this treatment, but it does not necessarily have to be the patient. England with a study that no valid PST. But on the other side, early work by Bruce Baker showed already that electrical stimulation of articular cartilage can restore cartilage. And this is was in the 70s. And so it might be worth it to follow up on that idea that with altered electrical currents, you can stimulate cartilage and reduce inflammation in the knee joint. Telomerase is a Nobel Prize technique and well marketed, and it's based on the protection of the chromosomes. And we all know that those chromosomes, they contain all the information we need in our body to regarding cell death and destruction of the joint. And this chromosome is the ends of the chromosome are protected, and if they break off, then the risk is higher that your cells get mutation, and then that it dies at some point and develops early osteoarthritis. So that can be something which should be followed. There is a Nobel Prize was earned with that technique, but it got quiet over the last years. But I think the idea is good, and you should keep your eyes open for that. And they protect the cells from DNA mutations and senescence and death at the end. Do you know this lady, Yulia Lipinskaya, one of the best figure skaters in the world? And she won everything. And at some point, she started getting joint pain and stress fractures without any accident, any known accident. And upon further workup, it was found out that she had eating disorders, anorexia, and that developed to osteoporosis. And at the end of the day, it was probably the low estrogen levels which led to her joint problems. And that was worked up, for example, in Sweden. And so that they found, the researchers there found that estrogen substitution was associated with a much lower risk to develop hip arthrosis now with patients with lower estrogen levels. So look at that, same for men. Transdermal bioidentical progesterone cream for the treatment of osteoarthritis, published in 2013 already. It might be worth to check on that, whether your patient, your young and active patients have a low T level and are developing because of that osteoarthritis. It leads indirectly to increased body fat, higher weight, oxidative damage, and increased inflammation. And all those factors can degrade cartilage. So what do I do when I see a patient like that? They saw Professor Nehrer in Vienna, and they saw Professor Lattermann in Boston, and they are at risk to develop early osteoarthritis. I try to identify them, to find out how they eat, what kind of job they have, what kind of sports they do, what kind of habits they have. Then I do the proper diagnosis with x-rays, as we heard, with lab and biomarkers. Then I do consulting regarding weight, exercise, and maybe surgical options to unload the joint, and then substitute, and then motivate, because it's a long, long process. That can be an example for testing the hormones, for example. There are a few values you should look for, the same with vitamins and same with diabetes workup. And then you substitute. That could be a program which is nowadays accepted as a normal and a balanced program. Antioxidants, vitamin C, and you can talk about the resveratrol 100 milligrams a day with capsules or wine bottles. So what is the idea, the value of hormones, PRP, and vitamins, and more? Basically, as we heard, you want a balanced joint. You want to calm down the inflammation, and you want to stop the joint from getting worse. And we don't know exactly how that works, but we have a couple of tools to detect early arthritis, to diagnosis, to prevent it maybe, and even to treat it. And with that, I thank everybody for the attention, and we want to draw your attention to the questions and answers we have here. Maybe I will open the Q&A.
Chris, I have written down as a bunch of questions from the question and answer session there. First question is actually to Andreas. Sorry, it's not Andreas, to Stefan, from Philip. Stefan, in their studies, I assume this is mostly pertaining towards the study from Alabama. Did you find any differences regarding ethnicities?
The cohorts there were too small really to say something about that, but there are interesting studies on the shaping of different joints in different ethnicities, which might be related to a high incidence of OA in other studies, especially for the hip. There are studies out there, and also when we look at the work from Hirschman in Basel, He found that different shapes or width of condyles in relation also when we look at women and men and the gender-specific OA incidence. So there are, I couldn't say that there are final any results on that. We haven't looked at that, especially our cohorts are too small to really say that, but it's a very good aspect. And there are hints from other studies that there's ethnicity does play a role in the incidence of OA in some way.
All right, and the next question, and that goes to probably to Chris actually and Stefan. So how do you guys think that the X-ray system is going to be valuable for cartilage repair when you are already detecting bone-related OA? And this is a question from Arthur.
Yeah, just to answer this quickly, it's a very good question. Actually, related to cartilage repair, what we are doing is probably not so relevant actually in the beginning, because MRI is really gold standard in analyzing cartilage lesions. But the X-ray is more like a big overview of a development of disease, and actually it's worldwide available. So we can actually use this in a assessment of big movements of or big developments of osteoarthritis in different cohorts, or related when you look at populations like overweight, inflammatory disease, and whatever. This allows you to kind of have a very high-flying overview about that. So we clearly, and we do this already, we go to also to MRIs and other things going with digital analysis. But the problem is that MRI and everything has too much information, especially when you look at the MOAC score or any other scores. They are very difficult to relate to clinical symptoms or anything else. So at the moment, we kind of look at the long-time consequences, and this can be followed in X-rays, but not, of course, at the development of a smaller defect progressing into a circumscribed osteoarthritis. This will be a different topic, but it's an interesting question.
Then we have a question here from Antonio Madrazo Ibarra. What is your opinion on subchondral treatments for early OA? That's we heard that before. Stefan mentioned it, and Christian Lattermann PRP drilling to reduce the pressure in the bone and inject PRP in different variations. I don't know how the others do that, Stefan.
Actually, I have no experience with that personally, but I think it's a good idea to look at the subchondral bone in the early phase of OA, and might be indicator, because also as Christian has mentioned, the inflammatory, which is quite also substantially linked to the metabolism of the subchondral bone. If you have inflammation in the bone through the Wnt activation pathways, you get also interaction with the subchondral bone. So there's a clear connection, and actually as a cartilage repair society, we have looked too long just at the cartilage and not at the subchondral bone. And I think now we see the whole context of the whole interaction of the different enzyme and cytokine and degrading and regenerating cascades when we look at that. And I think it's a good idea to also concentrate on the subchondral bone and the development of early OA. But I have no solution at the moment.
My approach
There's
to
a
that
question to, okay.
Sorry, my approach to that is a little bit different. You know, there's lots of efforts where people are trying to fix these subchondral bone lesions by injecting PRP or injecting, some sort of matrices or calcium products. The problem is you need to solve the original issue, why that happens. And, otherwise you're just basically trying again to fix potholes. You need to eliminate the reason for it. And the number one reason for these subchondral defects or subchondral edemas is typically there's an overlying cartilage lesion above it. Right. And I think it's simply a fluid shift phenomenon. Now, sometimes I see Chris shaking his head. You can have an overload situation. That's a different story. Right. In those cases, you get edemas without chondral lesions. But the problem here is the overload. And if you fix the overload, that goes away and you don't need to inject anything into that. Right. So this is where things like osteotomies, bracing, activity modification play a role. But if you have an actual edema that is connected to a cartilage defect, it doesn't help you to fix that edema. You have to fix the cartilage defect. I think we pretty much learned that. You know, now there may be a situation where this is palliative and you basically say, okay, fine, this is established OA and we have these typical OA related, you know, typically medial edge edemas. You can try to structurally improve the bone. That may last for a certain amount of time, but it's a temporary measure.
That's a good point, that we make it dependent on that. But for palliative treatments, it's in my hands fairly successful to do that. And I try that for some patients who want to be operated now at the moment. There's a question for Dr. Lattermann.
Yeah, just may add, because also in early OA, it's, I agree with Christian, it's more a regulative thing than just to fix a structure, because the regulation of the different cascades of regeneration or maintaining tissue structure, succulent bone, or the cartilage above, is more regulatory or regulation of bioactive markers than it is just filling then in the late stage where you kind of help the structure to maintain by cement or whatever you do. But that's a different story. But then you have already lost your race to hell because you're already in a way. And you can just maybe delay, but it would be more helpful to have on the regulatory side of inflammatory and anti-inflammatory cascades to work on that.
Yeah. What is your thought? Jérôme Guicheux asked that. What is our opinion regarding early OA and animal models? Christian, maybe you can enlighten us on that.
Yeah, so that's an interesting question, and in fact, actually, there's just been a very recent NIH webinar on that, where a lot of the OA animal models were yet again poo-pooed because they do have issues. They are not human models, obviously. They you know, they often are chemically induced or unnaturally induced. There is models in mice, rats, and rabbits, and also in larger animals, where you can actually mimic post-traumatic osteoarthritis by doing meniscal resections or ACL transections. And those models, I think, are fairly reasonable. The problem is that traditionally we haven't studied these really early on, where we would basically where we are now interested in humans. And I just found that out recently because I've been looking into a mouse model for early ACL injury, and I'm finding that there's a lot of data once the osteoarthritis is fully established, but there's practically very, very little data in the very early phases of after that injury. And the reason is because traditionally this has only been studied in end-stage OA. I think there's a shift there and we need to define that better. So I don't think they are bad. I think they can give us a lot of information, but we need a lot more information about these models in early time points.
Thank you. Monica asks, all the best for the new year, and thank you for your awesome lectures. Is there any correlation between PRP successes, treatment, and stage of OA and age? According to the Christian's lecture, it would make sense to expect a lower or worse results at a later stage OA because the inflammatory load in the joint is higher at that point. Can we say that like that, Christian? Could that be an answer?
I'm not sure. I'm not sure. And, you know, right now there is, I think, sufficient evidence in the literature to use it for symptomatic osteoarthritis. And it probably works through the mitigation of the inflammatory response and activated established osteoarthritis. However, I do believe that we yet have to hear more about PRP and its abilities, because what really intrigued me was the fact that platelets, for example, are extraordinarily high in their concentration of meresin. And if you can do something along the lines of what orthokine did, where you can actually concentrate some of these factors out of the PRP, with fairly simple methods or so, I think this may be opening a completely different line of treatment here. So I think there's more to come. Right now, I think it is reasonable based on the literature to use it for OA. The exact mechanism we don't know.
Okay. There's one more question, or we have lots of questions, and due to time restraints, we might want to keep them for us and answer them at a later time point. So everybody will, every participant will get answer for her questions or his questions. Here we have a question, Arthur Lesko. He wants to know, what is the role of hyaluronic acid in early post-traumatic osteoarthritis? Maybe Stefan, you can answer that. You did a lot of work on HA. What do you think about that?
Yeah, that's a very good thought, because we also have looked at inflammatory models where we have seen that the HA has a clear anti-inflammatory role. And also, as Christian has mentioned, this shift between M2 and M1 macrophages can be very much supported by hyaluronic acid to support the M1s who have a different kind of pattern of what they activate. So hyaluronan is far beyond just to be a viscous supplementation, as we have seen. So it makes sense also in the anti-inflammation way too. And also, when we look at other things like hyaluronic is very protective to chondrocytes in terms of when we look at cortisone, and cortisone is of course the most potent anti-inflammatory thing that we have. And if we add HA with that, we have a protective effect on the negative effect of cortisone. So maybe it's interesting for the future to have both acting. Yes, there is a role of anti-inflammatory, and also, of course, post-traumatic, we have a very high inflammatory phase, and this can be mitigated. And as Christian has pointed out, we have a long-term effect of this early inflammatory response to the outcome. So maybe it's not proven, I cannot say that, but experimentally it would make sense to use it.
And would you suggest HA post-operatively as well? Because it's a trauma in itself.
Yeah, the thing is, when do we use that? Because we have initial bleeding, we have a lot of other things going on, and there might be a certain time point when to use that. I think Christian was very early with cortisone in his experiments or studies. I don't know at the same time in his study using post-operative hyaluronan immediately after. So I think I would use it like 4 to 6 weeks later to have then use this as a impact on the homeostasis of the knee when the initial thing is gone, or the initial bleeding or swelling has already calmed down, maybe 2 weeks or something.
Okay, thank you. As I said before, a lot of more questions, and we will answer them if time is running out for us here. We will answer them via email or later on. Maybe to our speakers, did anybody see any increased number of joint pain, stiffness, joint effusions after COVID vaccination or boosters? Just an actual question. Did anybody see that?
So I have seen several patients who came back who tested COVID positive in anywhere as close as 1 week to about 3 months after surgery. And interesting is the majority of them report that during the time that they were acutely ill, they had a significant increase in joint pain, and particularly the joint that was operated on. No significant effusion or anything, it's just pain. And then once COVID resolved, that pain went away. I also hear that from my total joint colleagues that they observe that. So I think there is probably a general overall inflammatory activation that happens that certainly affects the recently operated on joint. Fortunately, I have in my patient population not seen any major bad outcomes, but we do know that obviously contracting at least the Delta variant in the perioperative period leads to much higher risk for complications.
I've seen maybe 10 patients 6 to 7 weeks after booster, and they complained about immobilizing joint pain, and that went away after quite a while. So I'm just surprised whether that has any correlation with the boosters or whether it's just cold in Switzerland. I don't know. So if anybody in the audience maybe has an idea about that and has seen something else, it would be interesting for me personally, for us to find that out. Otherwise, I would take the time now to thank everybody for the participation. You will have the chance to load down the presentations later on. And for your personal use, I mentioned personal use, and we will try our best to answer all the questions we got from all over the world. And it's very interesting to answer questions from Mongolia, from Nepal, from down under anyway. So thanks you very much for joining in, and hope to see you maybe in the exciting city of Berlin in April 2022. By that time, the Omicron wave has passed us, and we are all looking forward to talk to you and to interact with you and to drink with you and to discuss questions with you. Thank you all for being with us today. Thank you for the presenters. Thank you for ICRS for giving us a chance to organizing and setting up the stage for us. Thank you very much, and hope to see you soon.
Thank you.
Thank you.